So I want you to, imagine a really specific, incredibly high-stakes scenario right now. You are a triage nurse or maybe a clinical social worker, and you're sitting across a small room from a patient.
Right, under those buzzing fluorescent lights.
Exactly. And you are trying to predict this incredibly rare life or death event. You literally have to figure out if the person sitting right in front of you is going to survive the night.
It's an immense weight to carry.
It really is.
Yeah.
And honestly, how do they do it? Because usually when we talk about a medical diagnosis, there's this expectation of precision. Like you break your arm, the x-ray shows that jagged white line, and the doctor points and says, well, there it is.
Yeah, it's very binary. It's broken or it's not broken.
Yeah.
We really like things to be visible and neatly categorized in medicine. But in mental health, and especially in crisis care, that x-ray machine just doesn't exist. You are looking at a diagnostic landscape that is entirely invisible to the naked eye.
And that is exactly why today our mission on this deep dive is to unpack how clinicians actually navigate that invisible landscape. We are exploring a whole stack of fascinating clinical and historical sources to understand the science of suicide risk assessment. Basically, the science of asking the question that saves a life.
And this really matters for you right now listening to this because the whole landscape of mental health care is fundamentally shifting. I mean, back in July 2022, the United States launched the 988 Suicide and Crisis Lifeline, which was modeled directly on 9/11.
Right.
With that kind of infrastructure, universal screening is rapidly becoming standard practice. It's no longer just happening in locked psychiatric wards.
You see it everywhere now.
Exactly. If you go to a primary care clinic, a school counselor, or even just a general medical setting, these assessments are becoming just a normal part of the routine.
So we are going to give you a roadmap for how this actually works. We'll cover the pretty shocking origin of the field, the major medical misunderstandings that persisted for literally decades, and why a specific UK utility change completely altered how we view mental health.
It is really a history of trial, error, and some pretty massive paradigm-shifting discoveries.
But, before we can even understand how clinicians actually assess risk, we really have to clear up the biggest misconception that stops everyday people and sometimes even professionals from doing it in the first place.
Oh, absolutely.
I mean, I like to think of this old fear as being a lot like Fight Club.
Okay, Fight Club.
Yeah.
Yeah.
Because, the first rule of Fight Club is you do not talk about Fight Club. And for a really long time, the unwritten first rule of suicide was that you don't talk about it.
Yeah.
People were just terrified that bringing it up would somehow plant the idea in someone's head.
Yes, that is the single most persistent myth in the entire field. It's this pervasive idea that asking someone directly if they are suicidal will, push a vulnerable person over the edge.
Right, which sounds logical if you're scared, but...
But the clinical sources are incredibly clear on this. It is empirically false. There was this landmark systematic review in 2014 by Doddsey and colleagues that looked at this exact question.
And what did they find?
They found absolutely zero evidence that asking about suicide increases suicidal ideation. Zero. In fact, they found the exact opposite.
So it actually brings the temperature down.
Precisely. It reduces distress. And if you think about the psychology of it, it makes total sense. I mean, a person in an acute crisis is often dealing with this immense shame and isolation.
Yeah, they feel completely alone.
Right. So direct, plain language questions, literally just asking, are you thinking about killing yourself, takes this terrifying, isolating monster in the room and turns it into a tangible thing you can actually discuss. Euphemisms just create more ambiguity. So breaking that taboo is really the fundamental first step in harm reduction.
Wow. So where did this practice of direct questioning actually start? Because from the sources, it didn't come from some pristine ivory tower. It traces back to a psychologist named Edwin Schneidman in the late 1940s.
Yes, Schneidman is a huge figure here.
Right. So he was asked to review Veterans Administration hospital records in Los Angeles, and he just stumbled onto this cache of actual suicide notes.
And those notes completely changed the trajectory of his work and really the whole field of psychology, because reading them made him realize that clinical theory at the time was just way too detached from the messy reality of an actual crisis.
So fast forward a bit to 1958, and Schneidman co-founds the Los Angeles Suicide Prevention Center with Farborough and Lippman. And this is widely regarded as the first suicide prevention center in the world. But they weren't just writing academic papers, right? They were fielding real, live crisis calls.
Yeah, and that is a crucial detail for understanding the DNA of suicide risk assessment. It was born on crisis phone lines. It was harm reduction in real time.
Not just in abstract psychiatric wards.
Yeah, exactly. These clinicians were on the phone with people right in the middle of a spiraling event, trying to figure out if they needed to send the police or just stay on the line. They didn't have the luxury of time to, dance around the subject.
Right, they had to be direct.
They had to figure out what distinguishes someone who is deeply distressed from someone who is actually about to act. Schneidman even coined the term suicidology a bit later, in 1968, and the concept of postvention.
It was pure real-time triage. Okay, let's unpack this. We know we must ask, and we know from the data that we shouldn't be afraid to ask.
Yeah.
But for a huge chunk of the 20th century, the medical field took the answers to those questions and used them for the completely wrong goal.
Yeah, they really did.
They treated it like a prediction game.
That was the 20th century mindset, essentially. The historical framework in medicine was all about sorting patients into buckets, like low, medium, and high-risk tiers, and then you administer treatment based on that specific label.
I mean, it sounds totally logical. That's what you do in an emergency room for physical trauma, right?
Yeah.
The gunshot wound gets seen before the sprained ankle.
It makes sense intuitively, sure, but the data shows it was a massive failure for mental health. The real turning point in the literature is this massive 2017 meta-analysis by Joseph Franklin and his colleagues.
Oh, this study blew my mind.
It's incredible. They looked at roughly 50 years of research on suicide risk factors, half a century of data. And they found that predictive accuracy hadn't meaningfully improved in all that time. Categorizing individual patients into risk tiers performed only marginally better than chance.
Only marginally better than a coin toss. That is just wild.
And it gets worse. Researchers like Matthew Large pointed out a really dangerous side effect of this whole prediction mindset. He argued that formal risk categorization creates a dangerous illusion for the clinician. Well, think about what a low-risk label does to a busy triage nurse. It tells them they can step back, maybe under-monitor that patient, and focus on someone else. But the statistical reality is that the vast majority of suicides occur in people who were never flagged as high risk in the first place.
Because suicide is statistically rare to begin with, so high-risk categories are just tiny, tiny slices of the population.
Right. It's a low base rate event. A low-risk label is just a probabilistic statement about a massive group of people. It is not a safety guarantee for the specific, complex individual sitting right in front of you.
But wait, I have to ask, if we can't accurately predict who will attempt suicide, why are we doing assessments at all? If the sorting buckets don't work, what is that nurse even doing with that questionnaire?
What's fascinating here is how the field responded to that exact crisis of confidence. Leading organizations like the Zero Suicide Institute and the Joint Commission, they didn't just abandon the assessment. They fundamentally changed its purpose. They shifted the definition from prediction to risk formulation.
Risk formulation. Break that down for me. How is that actually different from prediction?
Well, prediction is about generating a label high, medium, low, and essentially handing down a verdict. Risk formulation is completely different. It's an ongoing collaborative narrative. It's the clinician sitting down with the patient and identifying the specific modifiable drivers of risk for them in the specific moment.
So it's more of a partnership.
Exactly. The clinician isn't a judge anymore. They are a partner trying to build a concrete safety plan based on what is driving the pain today and what resources the patient actually has right now.
So if the goal is no longer slapping a label on someone, the actual tools used in the clinic had to evolve dramatically, right? Because some of the old practices were, looking back, just completely illogical. Take the no suicide contract.
Oh, right. Also known as the no harm contract. This was widely used from the 1970s straight through the 1990s.
Yeah, and this was a literal written or verbal promise where the patient agreed not to harm themselves before their next appointment. I mean, to me, this sounds like making someone sign a piece of paper promising their house won't catch fire.
That's a great way to put it.
Right. It makes the person holding the clipboard feel like they have legal comfort, but it does absolutely zero to stop the flames.
And that is exactly how the research evaluated it. Studies consistently showed these contracts had zero demonstrated protective effect. None. And worse, they created that dangerous illusion of safety we just talked about. A patient could sign the contract, look totally compliant, and get discharged while still having an untreated plan and full access to lethal methods at home.
So if a contract was just a hollow piece of paper promising no fire, what is the modern replacement?
It's called the Safety Planning Intervention. It was developed by Barbara Stanley and Gregory Brown in 2012.
But wait, isn't a safety plan just another piece of paper? How does writing down a strategy actually stop someone in an acute crisis?
Because it's not a hollow promise to a doctor. It is a personalized, concrete, step-by-step cognitive map for the patient. You see, during an acute suicidal crisis, the prefrontal cortex, the part of the brain responsible for logical planning and impulse control, it essentially just goes offline.
It just shuts down.
Right. So a safety plan does the thinking for them when they can't. It maps out their specific personal warning signs, internal coping strategies they can do alone, social settings that provide distraction, specific professionals to call, and crucially, steps for removing lethal means from their environment.
It's like actually buying the fire extinguishers and mapping out the emergency exits before the smoke even starts. That makes total sense.
Exactly.
And it wasn't just the contracts that failed. The old static risk checklists failed too. Like there was one in the sources called the SAD Person Scale from 1983.
Yes, the sad person scale.
It was an acronym standing for demographic things like sex, age, depression, previous attempt. It was supposed to be this quick memory trick for emergency departments.
But studies, like the one by Cooper and colleagues in 2016, totally debunked it. They proved that these static scales performed terribly. And if you look at the mechanics of why they failed, it's pretty obvious. You just cannot sum up demographic data to capture acute human distress.
Right, because under that old acronym, a 45-year-old single man might score as moderate risk just for existing, while a 20-year-old woman in acute immediate distress might score low risk because she doesn't hit enough demographic check marks. It's treating a static identity like it's a clinical state.
Exactly. A checklist score is not a clinical decision, which is why the rise of modern tools looks entirely different. Today, clinicians use tools like the Columbia Protocol, also known as the CSSRS.
And the origin of the Columbia Protocol is actually pretty fascinating on its own. In 2004, the FDA put a black box warning on antidepressants, linking them to increased suicidality in youth.
Right, that was a huge moment.
Suddenly, the FDA needed a highly standardized way to measure suicidal events across all their drug trials. So Kelly Posner at Columbia University developed this protocol, and it worked so well it migrated out of drug trials and into everyday emergency rooms and schools. But how does it actually work? What makes it better than the SAD Person's acronym?
It uses branching logic. So instead of just adding up arbitrary points, it acts as a structured funnel. You start with a gateway question, something like, have you wished you were dead or wished you could go to sleep and not wake up?
Okay.
If the patient says no, you move on. But if they say yes, the logic branches down into the severity of that ideation, then into whether they have a specific intent, and finally, whether they have a concrete plan.
I see. So it guides the conversation naturally from vague distress all the way to immediate danger.
Yes. And for non-psychiatric settings, there is the ASQ, the Ask Suicide Screening Questions. That was developed by Lisa Horowitz at the National Institute of Mental Health, specifically for general medical nurses to use in under 2 minutes.
Wow, under 2 minutes.
Which is vital because a massive percentage of people who die by suicide saw a general healthcare provider in the weeks before, often for something totally unrelated like a stomach ache or a mild injury. You need a fast, reliable branching tool to catch that invisible risk.
But, having a great screening tool and a written safety plan is only part of the equation. A safety plan is great on paper, but the most crucial step of that plan relies on modifying the physical environment. And this brings us to a massive accidental national experiment in the United Kingdom.
Yes. The UK coal gas story.
This was incredible to read about.
It really is. So through the middle of the 20th century, the UK used coal gas to heat homes and power ovens. It contained high concentrations of carbon monoxide and was actually the country's single most common method of suicide.
Right.
But in the 1960s and 70s, the UK systematically converted its grid away from coal gas to natural gas, which is not lethal by inhalation in the same way.
And an epidemiologist named Neil Kreitman tracked the data. As coal gas was phased out, the overall national suicide rate plummeted. I mean, it didn't just dip a little, it fell substantially and stayed down.
And this is the defining proof of a concept called means restriction. Because the most critical finding wasn't just that deaths by gas dropped, it was that people did not simply switch to other, equally lethal methods.
So what does this all mean? Does just removing a specific method really stop the underlying intent entirely? Like if someone is cruelly determined, wouldn't they just find another way?
If we connect this to the bigger picture, it changes everything we thought we knew about suicidal intent. The coal gas story proves that suicidal crises are acute and time-limited. The intent is not a permanent, fixed state. Think of it as a wave that crests, peaks in intensity, and then breaks.
A temporary wave.
Exactly. If you can remove easy access to a highly lethal method during that specific, narrow window of crisis, you don't just delay a death, you often prevent it entirely. The wave crashes, the crisis passes, and the person survives.
That is profound. And you can actually scale that philosophy up from household utilities to an entire healthcare system. Just look at what happened in Detroit in 1999. The Henry Ford Health System launched a program with this impossibly bold name, Perfect Depression Care.
Yes.
Their goal was literally 0 suicides among their patient population.
And it wasn't just a catchy slogan either. They achieved it. But they didn't do it by just telling doctors to, try harder. They changed the systemic mechanics of how care was delivered.
Right. They built systematic screening directly into the electronic medical record at every visit. A nurse couldn't just bypass the questions. It was integrated whether you were there for depression or just a twisted ankle.
Yep, universal screening.
And if a risk was flagged, the system immediately routed them into rapid access to care, safety planning, and means restriction counseling. By fundamentally changing the clinical workflow, they saw a dramatic decline in deaths. I mean, they had several years where absolutely 0 patients in their health plan died by suicide.
Which became the prototype for the National Zero Suicide Framework that health systems across the country use today. Systematic, everyday risk assessment moves outcomes far better than waiting for a patient to show up in crisis triage.
So we've spent a lot of time talking about the physical environment, removing the lethal gas, restricting access to means. But the psychological and cultural environment matters just as much, making risk a constantly moving target. And here's where it gets really interesting to me. We actually get the vocabulary for modern psychiatric contagion from 18th century literature and opera.
You're referring to the media impact, the Werther effect, and the Papageno effect.
Exactly. The Werther effect is named after Goethe's 1774 novel, The Sorrows of Young Werther. It featured a highly sympathetic, romanticized depiction of the main character's suicide. It was so influential it was literally blamed for a wave of copycat deaths across Europe.
Yeah, David Phillips formally named this media contagion the Werther effect in 1974.
How we talk about suicide publicly, especially detailing the methods it bypasses the brain's natural defenses and can literally be deadly.
But the flip side of that is the Papageno effect. Named after a character in Mozart's opera The Magic Flute, who is actively talked out of suicide and shown a different path. We saw the mechanics of this life-saving effect play out in real life in Vienna in the 1980s.
Right, the subway cluster.
Yes, there was a tragic cluster of suicides on the Vienna U-Bahn subway system, and it was heavily driven by sensationalized front-page press coverage.
So Gerd Sonneck and other Austrian researchers sat down with the media in 1987 and created strict reporting guidelines. No detailed method descriptions, no front-page placement, no romanticized language, and subway suicides dropped by roughly 80%.
The cultural narrative acts as its own form of means restriction. But to really understand why this happens, we have to look at what is going on internally, inside the mind of the individual. This is where Thomas Joiner's 2005 interpersonal psychological theory of suicide is just so illuminating.
Joiner's theory breaks down the progression of lethal intent into 3 distinct pillars, right?
Right. First, there is thwarted belongingness, which is feeling profoundly alienated from others. Second, perceived burdensomeness, the absolute false belief that your existence is actively harming the people you love.
How sad.
It is. When those two combine, they create the desire for suicide. But, and this is critical, desire alone isn't enough to result in a lethal attempt.
This is the core of the theory. The third pillar is acquired capability.
Yes. Because humans have a powerful, deeply ingrained biological instinct for self-preservation. It is incredibly difficult to override the physical fear of pain and death. Joiner argues that the capability for lethal self-harm is not innate. It has to be acquired over time through habituation. Repeated exposure to pain, violence, or trauma slowly wears down that biological flinch response.
And this explains the ideation to action framework. The data shows that most people who experience suicidal ideation never actually attempt it, simply because they haven't acquired the capability to bypass that self-preservation instinct. It also highlights a major misconception in medicine. The idea that suicide risk assessment is just a one-time intake event. You check the box on day 1 and you're done.
Which is entirely false. Risk is highly dynamic precisely because things like burdensomeness and capability can fluctuate. Risk can escalate within hours. For example, the period immediately following discharge from a psychiatric hospital or during medication changes is one of the highest risk windows known to medicine.
The transition itself is a huge stressor.
Yes. This is why the Joint Commission in 2019 strictly required ongoing rescreening. You just cannot treat a moving target as a single static data point on a clipboard.
So let's bring all of this together for you. We started by looking at a triage nurse sitting across from a patient, trying to predict the unpredictable. What we've learned from the sources is that suicide risk assessment is no longer about crystal ball prediction. It's not about checking demographic boxes to cover a hospital's legal liability.
It's not at all. It is an active, collaborative safety net. It is rooted in asking direct, plain language questions without fear. It is about abandoning useless promises like the no suicide contract and instead building actionable, personalized safety plans for when a crisis hits.
And it is about recognizing that crises are acute, temporary waves. Modifying the physical environment to remove lethal means during those brief windows, whether it's changing the gas in the ovens or putting distance between a person and a firearm, it saves lives, period.
It's acknowledging that risk fluctuates constantly and the assessment must adapt with it.
Before we wrap up, I want to leave you with a final provocative thought to ponder on your own, building directly on Thomas Joiner's theory of acquired capability. We talked about how the ability to overcome the fear of self-harm is built through habituation to pain and fear. Joiner explicitly notes in his work how this capability is acquired. He lists things like prior attempts or combat exposure, but he also explicitly lists medical training.
That is a very profound and sobering reality.
I really want you to consider the quiet burden of that fact. The very nurses, doctors, and medics who are trained to sit in that triage room and administer these life-saving risk assessments might, by the very nature of their daily relentless exposure to pain, trauma, and death, carry a uniquely elevated risk themselves.
Wow, yeah.
Their biological flinch response is worn down just by doing their jobs. It fundamentally changes how we look at the people asking the questions. When we picture that clinician sitting across the room asking the question that saves a life, they aren't just reading a script. They are human beings, carrying their own vulnerabilities, doing the incredibly hard work of keeping the rest of us safe.
It's a really powerful reminder of the humanity on both sides of that clipboard.
It really is. Well, thanks for joining us on this deep dive. We'll see you next time.